Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Oh,
holy cow.
Hey, happy Tirzepatide approval day for obesity. Actually, it was 2 days ago. But
by the time this comes out, it'll be about a week later.
No, I don't know. We're gonna.
Or are you going to release it right away?
I want to post this right away.
Right now? Right today?
Right today. Like we should be doing this.
This is almost live, just like we got tricked into doing on the news last night.
Yeah.
Or at least I didn't realize it.
We were both on live TV last night going over what this means. So anybody listening to this, you probably saw a million posts from me and my brother. We don't make money from Eli Lilly. Not yet.
Not yet.
But we are very excited that Tirzepatide is now approved for obesity. We talked a lot about it when Mounjaro came out over a year and a half ago-ish.
For type 2 diabetes.
For type 2 diabetes, and now it's finally approved for obesity under the name Zepbound.
To Zepbound and beyond.
Yeah, to Zepbound and beyond. So for those who just need a quick refresher, Tirzepatide, GLP-1 agonist / GIP agonist, meaning it's a co-agonist. They hit the two different receptors in the body, GLP-1, glucagon-like peptide 1, GIP, glucose dependent insulinotropic
polypeptide. There you go. Yeah, these are hormones that come from your intestines that help regulate our energy balance, sugar metabolism, etc., through a variety of mechanisms.
Yeah. So what they do, the problem with our own, and this is actually just a quick tangent. People are always like, well, then let's just eat foods that increase our own GLP-1 and GIP. That's like pissing in the ocean, my friends, because your body's own endogenous, your own body's production gets broken down within minutes. And these supraphysiological special peptides don't get broken down quickly. And
we've been trying to do that forever, of course. We are shills for nutrition, for exercise, for all the lifestyle things. We have been shills for that forever. The problem is the data show that just doesn't work that well for most people who are truly struggling with the disease of obesity through the spectrum of type 2 diabetes, etc.
Yeah. Okay, so this new drug, pretty interesting. So we've gone over the history of anti-obesity weight management drugs in the past. We had, talked about phentermine being this sympathomimetic kind of like amphetamine-like drug, working on the adrenaline system, and talking about topiramate when you add that to phentermine, bupropion, naltrexone, metformin, all these different drugs. And then the newer GLP-1s, they had liraglutide, and then semaglutide in 2021 as Wegovy. So we went from kind of the 5 to 10% weight loss, then to kind of the 15% weight loss. Tirzepatide, we talked about this before. We talked about the Surmount trial. Now we're in the 20% weight loss. And even when you take this longer, we talked about this last podcast. We talked about the Surmount 4 top line results, right? We talked about that. Mm-hmm. And the longer you take it, we may be hitting around 25% average total body weight loss, which is pretty ridiculous because bariatric surgery, you're starting to get in the 30s. It's in the 30s. Yeah. So we're starting to get close to that with a medicine.
And going back to why that matters, again, we don't care about what the weight is. And this is one of the things I tried to articulate on the news last night when I was under the gun. But we care about what does that mean for people's actual health benefits. So when you start getting over 10, 15 or more % weight loss, what that reflects is improvements in all the health measures that we actually care about. Putting type 2 diabetes into remission, getting rid of fatty liver, the risk of the fibrosis, getting rid of sleep apnea, improving knee arthritis, all the things. That's why the weight loss that we talk about matters, not because of the scale weight. And it's not a cosmetic disease because it's actually about the health.
Very easy for my brother to say because he had abs in utero. As we all know, the dude walks around like a Greek statue. Year long.
Oh yeah.
Basically eat salmon and frozen vegetables all day.
And
so, but it is true. We have to think of this obesity as a chronic disease. Like if we get into the vanity weight loss, then like what are we doing? We have to think about the improvement of health.
It really is about the health. And yes, and to that point, everyone is different. Everyone has a different genetic background, a different lifestyle background, a different exposure to our obesogenic environment. And yeah, I was fortunate for that specific area, but other people have not been as fortunate. And the disease of obesity is very pervasive in society. And there's a reason we're studying these new medicines and very excited about the benefits and the results that we've seen so far. And now getting this medication approved. Now, that said, before anybody gets too excited, we are hopeful for improved access, coverage, and cost, but we know that's not going to be great right away.
Yeah. So what does this mean? We've already, like a year and a half ago, went over the Surmount 1 trial, and when Mounjaro came out, this drug it's exactly the same. It's just under a different name called Zepbound. And it's FDA guidance. So Mounjaro technically only approved for type 2 diabetes. Zepbound approved for obesity. That's a BMI of 30 and above, or a BMI of 27 and above, plus a comorbidity such as prediabetes, hypertension, obstructive sleep apnea, that type of thing. What else does this mean, though? Like we've already gone over this drug I mean, people think we basically must be making money from this because we love it.
We're not.
I love it. I love it. I love it.
It's just very, I mean, the thing is, so many people respond. When we talk about those older medications, we talk about, well, how many people respond with clinically meaningful weight loss? And so, when we talk about like the phentermine topiramate, brand name Qsymia, we think we're getting, more than, 2/3 of people getting like 5% weight reduction, knocking on the door of a lot of people getting 10% weight reduction. And that was really, really good for that. Well, now we're talking about almost everybody getting more than that 5% weight reduction.
Yeah, pretty much.
As long as, and remember now, people with type 2 diabetes have less of a weight reduction on average than those who have pre-diabetes, all the other complications, as long as they don't actually have criteria for type 2 diabetes in all the studies. But, in the Surmount 1, just to go back to that, I mean, darn near almost 2/3, I think I said last night, 2/3 of people were getting 20% weight reduction. It's really just more than half. Over 2/3 were getting 15% weight reduction. But that is so meaningful for people's health.
What about how many people get 10%?
So on the highest dose, it was like 84%. So when we go back all the way down to the 5% threshold, it was like over 90%. So only 10% of people were not responding to this medication. Now, those people need some extra help, extra evaluation, maybe genetic things, other issues going on. But in general, for people who don't have diabetes, that is an amazing amount of weight loss. And then, I mean, even in people with type 2 diabetes, when we look at all those Mounjaro trials, we're still talking about, 13, 15 or more percent weight reduction, that we see like in the Surmount 2, that was actually for weight reduction, but in people with type 2 diabetes, it was like 15% weight reduction compared to 3% for the placebo, which is really, really meaningful for diabetes.
Let's dive into what this means differently.
Well, are we going to talk about Surmount 3? Didn't we want to do that?
Yeah, let's talk. We'll talk about that in 1 second, but just the logistics of Zepbound. Zepbound, again, there's probably people listening to this going, I already took Mounjaro. I already know about this drug. I've listened to you idiots talk about this drug for a year and a half now, shilling this medicine. Again, no differences. I will say, in the package insert, there's a little comment about monitoring for changes in mood and depression and suicidal ideations. They have that on every weight management anti-obesity medicine. This goes back to the Rimonabant days, I believe. I was talking to my buddy Tom Wadden. He's my buddy now, but he's given me the history of this. Kind of one of these prolific researchers. I've been lucky to get to know him, but Rimonabant, we've talked about this before, but endocannabinoid system antagonist, cannabinoid CB1 or 2, I don't remember.
Yeah, well, and it was peripheral and central, and so whatever the opposite of getting high is, that was blocking that.
Yeah, so imagine using marijuana for whatever reasons, and you get appetite increases. We actually use Marinol. It's actually prescription type of marijuana for
cannabinoid, we'll call it.
Yeah, cannabinoid, I should say, for increasing appetite. So now they want to go and block that. And it makes sense. It'll help people with appetite. But it caused psychosis, I believe, and
suicidal ideation. And that really did happen. I mean, it was approved in Europe for a while. It never got approved in the United States. It had very good cardiometabolic benefits, but you can't do that at the cost of mental health. Mental health is actually part of the disease we're trying to help treat.
Yeah, we can't do that. Always benefits and risks. So we don't want to just help people lose weight while causing other issues. So the concern has been for every anti-obesity medicine to monitor for this. There have been case reports, as people have seen in the headlines, of I took semaglutide. They say Ozempic. It's always Ozempic. It's never anything else. It's always Ozempic.
Right, which is only approved for type 2 diabetes, but the media decided to screw the pooch on that one. God.
It's the colloquial term for all of these. Zepbound will be Ozempic too.
God, that'll make Lily really happy.
Yeah, that'll be.
Or maybe it'll just make Novo mad. I don't know.
I don't even know.
We don't get paid by them, so it doesn't.
We don't get paid by either of them, not yet. Anyway, so there have been some case reports of suicidal ideations. I monitor this. I ask my followers. There have been a few people that said, you know what, I did notice my mood change while and they take it off. So it is important to monitor patients. So like, I'm sure when they come into you ask them how they're doing. I don't know if
I think everyone should be monitoring everyone for that though. We should be monitoring ourselves. The physician should be monitoring patients. We need to monitor our friends. I don't know. There's a lot of bad mental health stuff going on these days. And so I think we all need to look out for each other no matter who we are and what our roles in life are.
Yeah,
so and we should all be doing that.
It's not known whether the drug actually has this effect. I will say there are anecdotally, I've seen a few patients say like, yeah, no, I did. It dampened my mood a little bit. Nothing like suicidal ideations, like I'm going to have a plan and follow through with it type of thing. But yeah, reasonable to monitor. So that's one of the differences.
I'll say I don't actually think I've had any patients say that. And I have a ton of patients on this for type 2 diabetes, of course.
Yeah. It's not on the package insert for type 2 diabetes.
Right.
It's always obesity.
And so it's, I don't know. I'm a little skeptical that there's any real concern, but I think we need to have that concern for think about bariatric surgery studies, right? Yeah. There is increased, suicide with that. And I think it runs a lot deeper, and it probably gets back into, the stigma and internalized weight bias of obesity itself, the complications of, mental health struggles with the whole thing. So it's a complex deal in itself.
Another difference in the prescribing information is the package. I always keep saying that package insert is the maintenance doses. Because of the way it was studied, they looked at 5, 10, 15. And so I titrate to what's tolerated and what's most effective. And that could mean 2.5. It could mean 7.5. It could mean 12.5. It doesn't mean it has to be 5, 10, and 15. However, if they put that in the package insert, that means that insurances might go, hey, you can't just be on this 2.5.
Also, so this has been happening with Mounjaro, by the way. So I literally I think I had a patient today who's been on 12.5 for 4 months or something. Yeah. And my actual question was, because those are very literally approved, like you just said, for transitional dosing, right? So you use that to go from 5 to 10 and then from 10 to 15. So I think they're not going to produce as much of those. They're really literally meant for each person only have 4 weeks at a time. But right now the supply has been so goofy that they've had to use whatever's available. So I don't know about that. I tell people not to get attached to those doses, because really those are not for long-term use, just purely by the, approval and technicalities of it and potentially the supply. But we'll see.
Yeah. But so the difference is, though, I'm looking at the Mounjaro, and I don't believe, they don't say that. I said it's different. It's different in Zepbound. In Zepbound, it literally says maintenance or 5, 10, 15. It doesn't say it here in Mounjaro. That's why I was like, this is
different. It says those are like the doses, though, that are... The other thing that's different is that the way it's recommended based upon clinical response.
Actually, you know what it says?
Is glycemic control.
Yes. Okay. So it says after 4 weeks, increase to 5 milligrams once weekly, if needed.
If needed for glycemic control, that's the difference.
And if needed, for glycemic control go up 2.5 increments. So like in this, technically, you wouldn't be able to. Okay, so it's just different the way they have it written here.
Right. And that's because of the different indications, the ways it was studied specifically for diabetes versus weight.
Yeah, you're not titrating Mounjaro for weight. You're titrating for glycemia.
Except that, if we got rid of brand names like we did in med school, the way we were taught, then it wouldn't actually matter. So the way I've been practicing is I have been increasing Mounjaro, Tirzepatide, based upon the clinical requirements to get the health benefits we need, often from the weight reduction. So yeah, to be honest, it's been less about glycemic control because people do really darn well with their glycemic control on this medication, but sometimes they need a higher dose to achieve the benefits that they will get from further weight reduction.
Here's what people want to know. When can they get their hands on Zepbound? Everybody. So I'm hearing after Thanksgiving, it's in a few weeks. I'm hearing the first week of December, the second week of December.
Yeah, that's what they're saying. I think, I think even the company has sort of planned that out based upon their reps and people trying to get us samples or whatever.
Okay. So. Next, quick rapid fire. Next thing, will insurance prove this? We don't know. The thing is, they need to get on formularies. They're going to work this out with the PBMs and insurances. It's a mess. They want
all the things that make our healthcare dysfunctional. They have to work with.
Yeah, we don't know. They have coupons. It's $1,000, but with a coupon, if you have commercial insurance and it doesn't approve it, it's $550. If it is on the formulary, it'll be around $25. Again, the problem is the coverage. I mean, not enough insurances are going to cover it. The cost isn't low enough in the United States for the people who need it the most. Yeah. So we need to keep advocating for everybody. Yep. And we don't recommend compounding this as usual. Other questions. That's basically it. Let's go into Surmount 3. I was at Obesity Week. My brother didn't get to go. I heard my friend Anya Yastebrov, who's friends with my brother too. She presented this trial. If you want to just quickly go in it, we have a few minutes.
Yeah. So this is, I love these types of trials because what they did was they took people with obesity, technically a BMI over 27, with some sort of obesity related complication like high blood pressure, prediabetes, etc. And they first got everyone into a 12-week intensive lifestyle intervention. So when we talk about intensive lifestyle interventions, that's like, meeting weekly with your health coach, your dietitian, et cetera, using meal replacement shakes, all the intensive dietary things to achieve greater than 5% weight reduction. So anybody who was able to do that, they got to go into the trial. So of those who were able to achieve that. And if you didn't do it,
you were SOL.
Yeah, for this trial, yes. I think so. That's the case. That's how it's been for these trials. So there were 5, let's see. So of 806 people that kind of started it, 72% were able to achieve that 5% weight reduction, which is pretty good. I think
12 weeks, that's pretty good.
Yeah. But remember, this is intensive behavioral therapy. Yeah. It's not so pragmatic. And so those people who achieved that, on average, then got about a 7% weight reduction. Then they were randomized to Tirzepatide, now known as Zepbound, or placebo. And then they went on to finish over 72 weeks. And there was another 18% weight reduction in those, on average, in those who were randomized to Tirzepatide. The placebo group, now remember, these are people who responded to the lifestyle intervention, so that's pretty good, and they were able to somewhat maintain weight. They slowly regained, ultimately ending with close to a 5% total weight reduction, but that group that was randomized, 18 plus the 7, they got about a 25% overall weight reduction compared to the 4.8 for the placebo group. I mean, that is spectacular, and that's after responding to intensive behavioral therapy. Very cool.
Yeah, well, we don't know. They haven't done it to where they did one group with intensive versus one group without it. It's just, it would be kind of interesting to see if it's additive at all. They haven't actually done that head to head, but it seems like if you respond to diet and exercise, you're going to respond to these medicines and you're going to keep going even further than maybe what would be expected. So it's kind of,
I mean, they did that, and I think there is one still pending, if I'm not mistaken, similar to the semaglutide one, where where it didn't really do a lot more than what it did in the regular trials. The intensive behavior, is that what you're talking about? The intensive behavior therapy plus semaglutide, the absolute result wasn't a lot better than it did without intensive lifestyle therapy.
Yeah, we're going to see. So, I mean, actually just to give us a plug at, Weight Watchers, what we don't think there's going to be any additive weight loss effect to lifestyle. What we do think it matters still for quality of life. So we're Docs Who Lift. We think resistance training and protein are important. We're about to go on with Stu Phillips here in a moment, protein guru, and kind of go over protein recommendations. But micronutrients, fluid, we want to make sure people are staying hydrated, because otherwise people think that these things cause kidney failure. And the only way they can do that is not directly to the kidney, but because you're not taking in enough fluid because you're just nauseated.
Yeah, stay hydrated. And by the way, speaking of that, the side effects, people want to know about that. And we've talked about it with Mounjaro because it's the same thing. But a fair number of people get some sort of nausea, some vomiting, diarrhea. But the amazing thing about the trials is that despite some of those side effects, they were tolerable enough for like over 90% of people to stay in the trials. That's a pretty good statistic, I think, to tell people that if you can weather the storm, do some of the dietary efforts correctly to help minimize the nausea and diarrhea, constipation, etc., then they will get better and you'll tolerate it better and do very well with your weight.
Yep. So not mutually exclusive. Lifestyle still matters.
Lift weights, please.
Quality of weight loss matters. Quality of diet probably matters for the long run. It's not going to, like weight loss, you're going to lose weight. You're going to be in a calorie deficit. We don't want you to, I don't think these drugs are inherently catabolic, but if you're not eating much, you're going to be in a catabolic state.
Some sort of strength training. We got to keep our muscles happy and healthy.
Twice a week, if you can. If you can't do that, once a week.
Anything's better than nothing.
Walk. I don't know.
Everything.
Just do it.
That's good.
Just do it.
Just find a way.
Anything else?
A little bit.
Zepbound.
We'll talk more about it soon.
Yeah.
And I think, the next thing we're going to have to talk about in a timely fashion is going to be the actual publication results of the cardiovascular outcome trial for semaglutide.
That's coming up tomorrow.
That's coming
I believe it's coming
this
out
weekend.
Tomorrow.
Yeah. All right.
We'll probably tape that next week, and we'll release that probably early. So anyway, thanks for listening. Share this with somebody. I don't know, whatever. Just give us a review for the love of God. For the love of God, give us a review. A good one.
Hopefully a good one.
Thank you.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.